The second disease that we're going to be talking about is tuberculosis, and the vaccine for it is called BCG. A lot of countries have removed this vaccine from their schedules for one reason or another, mainly due to low levels of TB in their country. This lecture is likely to be a very long video as well, but everything beyond that should be a lot more straightforward. TB is a very peculiar infection. A lot of countries have dedicated MD specialists for treating people with TB, physiatricians. In others, TB is taken care of by pulmonologists or infectologists. TB is a disease that can affect almost any organ, that has dozens of clinical manifestations and even has dedicated courses in med school for studying specifically TB. And I do not by any means aim to cover all of that. I'll try to give you some idea of what the disease can look like. Something to form your basic understanding of what we're dealing with, what the vaccine is and what it's supposed to do, because this one is gonna be a little bit tricky. First, we're gonna start with the pathogen again. TB is caused by a bacteria called Mycobacterium tuberculosis. It differs greatly from other bacteria, however. Most notably, it has a very unique structure of its cell wall. This results in greater resistance to the influence of outside factors. MTB can survive for a very long time outside of hosts, and it's resistant to very harsh conditions. It also makes it harder for our immune system to attack and kill it. It also gives resistance to a lot of antibiotics, unless they can penetrate the cell wall. On the other hand, it also provides some unique targets for other antibiotics to attack, and there are some specific drugs that only work against MTB. 2. It takes a very long time to multiply. It can take about 3 months to grow a culture of mycobacteria on a dedicated nutritional medium, and this is actually the golden standard for diagnosing TB. We have other quicker methods as well, but they still require a positive culture to be 100% sure that we are dealing with tuberculosis. The spread of it. The sad truth is that almost every single one of us is very likely infected. It may not be true for some developed countries with incredibly advanced hygiene culture, but for the rest of the world, most of the population has likely come in contact with MTB at one point in their life. And yes, I'm not kidding you, the chances of you never ever contacting MTB are actually extremely low. Whether we develop the disease or not is determined by some other factors, such as individual susceptibility, the influence of outside factors on our health, and immunosuppression. The last one is especially prominent in people with AIDS, as one of the most difficult problems they can face is actually AIDS complicated by TB. The infection is spread in two main ways, airborne and through direct contact. Before we continue, there is one more immunological defense mechanism that we have to look at. TB is a very unique case in terms of how our immune system reacts to it. When we first contact the bacteria, all the normal processes kick in. Antigen-presenting cells migrate to the source of infection, in most cases the respiratory tract, and consume the bacteria in a process known as phagocytosis, which we discussed previously. However, MTB's thick cell wall renders normal attack mechanisms to be useless. The bacteria has been consumed but cannot be killed by ordinary means, and antigens from it cannot be presented to young cells to form strong, long-lasting immunity. This process is known as unfinished phagocytosis. The bacteria doesn't care about any of our defensive mechanisms and just simply lives inside of APCs. Virulent MTB strains can even multiply inside and kill our immune system's cells if they get around to it, or simply outlive them and then consume whatever's left. What our body cannot kill, it tries to isolate. So instead of killing the bacteria, APCs attract more cells that form connective tissue around and isolate them from healthy tissue. This formation is called a granuloma, and it's designed to limit the infectious process that our immunity can't contain through normal day-to-day measures. And this is the gist of primary tuberculosis, granuloma formation. So let's slowly slide into clinical manifestations. There are 3 distinct groups of TB forms: primary tuberculosis, secondary, and disseminated. If I wanted to go through each and every single one of them, this video would be forever minutes long. First and foremost, TB is mostly a chronic, slowly progressing infection. The main reason behind it being that it takes weeks for MTB to multiply. Acute forms can manifest in severely immunocompromised patients, but for the most part, the process is rather slow. Anyways, it means that acute forms are very rare and the disease usually manifests with a bunch of non-specific symptoms over several months. Chronic cough, which can produce some bloody sputum after several months, weight loss, which is rather slow and occurs over the course of several months, and ironically the most specific symptom for TB is night sweats and fever that occur in the evening or at night. It's usually very mild and a lot of people don't actually notice it. Primary TB mainly affects children. Today, it's actually one of the rarest forms of TB as well. There are several ways that primary TB manifests, and for simplicity's sake, let's use a classic and most notable example. Primary TB is characterized by a triad of symptoms on a chest X-ray: a granuloma, an inflamed lymph node or a small group of lymph nodes, and 3, an inflamed lymphatic vessel connecting the previous two. The last is not 100% necessary, but is common enough to include it. The most commonly affected part is the right upper lung lobe. Clinically, we have the same exact symptoms as mentioned above, plus chest pain and difficulty breathing are also possible. In uncomplicated cases, the symptoms regress, the granuloma becomes encapsulated, calcified, and petrified over the years. Complicated cases are more common, however, usually by pleuritis, the inflammation of the pleural cavity, usually manifesting with chest pain that increases upon breathing, atelectasis, a collapse of part of the lung which can result in difficulty breathing, and dissemination to many lymph nodes, formation of lung caverns or bronchial fistulas. These are all bad, as they imply the migration of infection to healthy parts of the lungs or even to other organs, and also more tissue damage. The most severe cases present with pneumonias and meningitis, which both have very high mortality. Disseminated TB. Certain authors don't include disseminated TB as a separate form. In my country, it's common to talk about it as a separate form of the disease, and I'll view it as such. Dissemination can occur in people that suffer through primary forms of TB, either as a complication or sometime in the future after primary TB. In the latter scenario, dissemination doesn't come out of nowhere. Between the resolution of symptoms of primary TB and granuloma calcification, there is a time period. During this time period, the infection can reactivate if the patient somehow becomes immunocompromised. Dissemination is a medical term for spreading. TB can spread through lymph nodes within the lungs or through blood all over the body. Lungs are still the primary concern though, as these forms are generally associated with fairly high mortality rates due to respiratory failure. Now, we've covered extensively the clinical symptoms of liver disease, and you're now aware why most of them are pretty bad. Also, shown a person with severe cirrhosis, you could probably recognize that he's severely ill, has liver failure, and that it's a tough condition to treat. Now let's own some more of our newly found clinical skills and talk about respiratory failure. We'll be talking a lot about pneumonias in the course of this discussion, and it's important that we understand what respiratory failure looks like and why it's bad. Our body uses oxygen to make energy for it to function. Our body simply can't survive for long without precious oxygen. If there's no oxygen supply, the cortex of the human brain dies within 3 to 5 minutes. Other organs are a bit more resilient, but don't expect a person to make good recovery if they have no oxygen supply for more than 5 minutes. Two main systems are responsible for transferring oxygen to our tissues: respiratory system and cardiovascular system. Respiration from a physiological point of view is a very complicated process divided into 5 main stages: breathing, oxygen diffusion into the blood, blood transferring the oxygen to tissues, oxygen diffusion into the tissues, and tissue oxygen metabolism. Stages 1 and 2 are usually the ones we address when talking about respiratory failure. These stages are mainly related to associated lung damage. In pneumonias, clinical manifestations come from the loss of our lungs' functional capacity. There's the microbe damaging healthy lungs, which cuts them out of the breathing process, and there is also inflammation. Inflammation also impairs our lungs' function, and there is edema, and edematous lungs make it much harder for oxygen to pass through them and into the blood. Normally, our organism has reserves for oxygen delivery. The supply in healthy individuals is 5 times greater than the demand for oxygen, and the supply can also increase drastically to meet the demand. Normally, our brain does the breathing on its own. There is a respiration center that controls mainly one muscle, the diaphragm, to contract. But there are other respiratory muscles, most notably intercostal ones. We breathe at a respiratory rate of 12 to 20 breaths per minute, a volume of 300 to 700 milliliters per breath. Normally, this adds up to 5 to 6 liters of air per minute, and it's what allows us to function normally. The clinical signs of respiratory failure are signs of our body trying to compensate the lack of oxygen, and signs of severe respiratory distress are signs of our organism running out of power. In mild to moderate respiratory failure, there are attempts of our organism to compensate for lack of oxygen. Patients become agitated and nervous. It's almost at the level of an instinct that we become this way when lacking oxygen. Failure to breathe causes stress and panic initially. It's a defensive response to get away from danger, the very reason we might be lacking oxygen in the first place. Some classic experiments involve putting mice and draining air out of their rooms. Mice become agitated and actively look for a way out. As they get worn out, however, their brains start to lack oxygen and to shut down eventually. Same for humans. As respiratory distress gets worse, our brains start to shut down and patients go into coma. Our body tries to compensate lack of oxygen by trying to breathe more of it in. Our respiratory rate increases and can go to as high as 40 to 50 breaths per minute, and our lungs also try to inhale more volume. Clinically, it looks like this. Patients breathe much faster and can take deeper breaths, often involving additional breathing muscles. It's also much easier for us to breathe when sitting up rather than lying down. Patients with respiratory failure will often sit up, and many patients with chronic respiratory troubles will often sleep in chairs rather than lying in bed. If only one lung is damaged, or patients experience difficulty breathing due to broken ribs or fluid in pleural cavity, they will often lie on the damaged side. The mechanism is quite simple. It limits the movement of that damaged side when the patient is breathing. In severe cases, ones where patients are unable to compensate using these mechanisms, their breathing starts to shut down as well. The brain can't just lack oxygen in one place. If there's trouble, it'll also follow the rest. Eventually, the respiration center can also start to experience lack of oxygen, and as it does, patients' respiration rate starts to slow down. Their breathing muscles get weak and they eventually exhibit pathological forms of breathing. An example would be taking deep breaths with long pauses, taking rapid shallow breaths, or combining those deep and shallow breaths with a regular respiration rate. These are generally the signs that our brain is experiencing severe lack of oxygen and the patient is likely to die soon. Some common signs of lack of oxygen can also be seen on the skin. When there is a lack of oxygen, our lips, ears, and the tip of our nose and the tips of our fingers are good spots to look at. They can either be pale or turn bluish, both indicative of an oxygen delivery problem. Bluish color is common in primary respiratory problems, and pale patients are generally ones with a failing cardiovascular system. Our heart tries to compensate the lack of oxygen as well. At first, the patients get stressed out and agitated. Our heart starts to pump more, making sure it can deliver more blood. This results in increased heart rate and blood pressure. Later on, as the patient becomes increasingly worn out, blood pressure greatly drops, and at the very late stages, the heart starts slowing down as well. Well, I've established a little that liver failure is difficult to treat, so let's elaborate a bit on respiratory failure. Sadly, it's not as straightforward as there can be numerous reasons why someone's failing. The first thing to do is take care of the root cause. In pneumonia, it's a rather straightforward but not a quick process. Antibiotics take time to work and the patients can die due to other complications on the way. Management can range from simply supplying additional oxygen to executing mechanical life support. To be fair, it's quite crazy how severe certain patients can get due to respiratory failure and still make it out alive. In the era of mechanical ventilation, only a relatively small percentage of patients actually die because of failure to breathe. Most patients that die from acute respiratory distress syndrome, the most severe form of respiratory failure, die due to other complications: renal failure, sepsis, impaired blood coagulation, and others. While respiration problems can be managed very well, patients still often die due to complications of them, and it's never a problem we can simply ignore. And while I'm at it, let me elaborate on one more point. We've briefly mentioned that pneumonias are problematic for children, and here is why. Children are unable to compensate respiratory failure as well as adults. Their additional respiratory muscles are underdeveloped, as well as their lungs and immune systems. Infection can quickly spread itself, and the child won't be able to breathe in as much oxygen as he would need to. Problem being, even in severe cases, an adult can spend several hours trying to get help and not dying in the meantime. With kids, the time frame to get help is significantly lower, and they get to the most severe complications of respiratory failure rather quickly. Secondary TB, aka post-primary TB. Let's clarify two things. First of all, you don't need to suffer primary TB in order to have secondary forms. Almost all of us come in contact with MTB, and given how most of us have competent immune systems, we don't develop clinical symptoms. The pathogen remains in our body, however. Second, there are 8 distinguished clinical forms of secondary TB, and I don't mean to go through each and every one of them. Some are more deadly, others are less so. The symptoms for all of them remain more or less the same. In severe forms, breathing problems start to skyrocket and patients die of respiratory failure. Other forms can affect much smaller areas and thus cause less symptoms in patients. The natural tendency is that milder forms can either regress and resolve with certain parts of the lungs undergoing fibrosis, or progress to more severe ones damaging more and more of the involved lung. Generally, if a person does develop secondary TB, the more likely scenario is the second one. Either way, with TB there is a distinct tendency. If your immune system can fight the bacteria, it will do so effectively. And if it can't, the disease will progress, and as more and more bacteria multiply, more severe forms of the disease will become almost inevitable without treatment. Also, TB is a disease where the concept of virulence and infectious dose come heavily into play. In some countries, many forms of TB are primarily resistant to a lot of antibiotics. These strains are also generally more virulent and can infect people with immunity. Infectious dose is also important. I'll use corona as the example yet again. Physicians had a reported 3-fold increase in the likelihood of contracting the disease, no matter their specialty. It's also no secret that younger patients had a significantly lower risk of developing the most severe of forms of the disease. Out of the young people, critical care specialists were at the highest risk of dying and also developing severe clinical forms. Reason being, they worked with patients who spread a lot more of the virus, and also they worked directly with the patient's respiratory tract by placing tubes into tracheas and conducting mechanical ventilation. TB is no different. You're much more likely to get ill if you have to face the same issues, and people who work with TB pneumonias don't just use respirators, they use full-on gas mask with isolation. But TB is also not nearly as contagious as corona. Or actually, it spreads very well and infects a lot of people, but doesn't do so in large enough doses to cause harm. In my city, there's one facility responsible for taking in most of the TB patients. It's also the facility where med school students have their classes on TB. And it's a small remote clinic just outside of town. There are 2 buses that go there, and almost every single student and patient to ever visit the clinic had to use those buses. The staff of the clinic are completely aware how one can easily get TB from the buses, and there's even a joke going on about it. There's a higher chance you'll get TB in the bus than at the clinic. Well, you're gonna be surprised. After years of this practice, only a few cases of clinical TB have actually been registered among students. So despite all the odds being stacked against the people, the disease doesn't actually spread very far and wide. Maybe the fact that all of us have been vaccinated against TB actually helps, but we'll never know for sure. Overall, the disease presents a lot of challenges. Treatment isn't very benign either. TB requires antibiotic schemes with at least 4 to 5 different antibiotics lasting 6 and up to 24 months, depending on certain factors. Many of those antibiotics are quite toxic, and it's rare for patients to experience no side effects from treatment. Moreover, MTB develops resistance to antibiotics fairly quickly. In some countries, more than half of new TB cases are resistant to several first-line agents, and patients have to start from secondary schemes, which are also responsible for more side effects and require longer courses of therapy. There's also no guarantee that these treatments will rid you of the problem. Many patients have to undergo additional courses of therapy. It's literally an infectious disease that you can take treatment for years and still be ill and even get worse in the process. Mind that we've barely scratched the surface of TB, as TB can affect any organ whatsoever. Just talking about pulmonary TB is a challenge, and I'm definitely not bothering explaining every single other scenario. The rest of the principles are, however, the same. No matter what organ is involved, it's a disease that's very difficult to diagnose and to treat. The vaccine component is fairly straightforward. The vaccine is called BCG, and it's a live attenuated strain of MTB. BCG is the single most unique vaccine to date, and there are plenty of things to talk about in here. First and foremost, it's generally administered in the first 5 days of a child's life. A lot of hospitals do it upon discharge for simplicity. Following the general rule, we administer before times of most likely contact, and incidentally we can come in contact with MTB at pretty much any point in our lives. Thus, the idea is to vaccinate as early as feasible. One particular thing needs to be mentioned about this vaccine. It does not create 100% guaranteed immunity. Instead, what it does is expose you to a particularly mild strain of MTB and allow you to develop some form of immunity. To clarify it further, BCG doesn't exactly protect you from TB. What it does is significantly lower the chance of developing primary TB and its progression to more severe forms. If you do happen to still get TB, there's a high chance that you will resolve without complications and won't progress to more severe forms. The vaccine is given intradermally, meaning into your skin. Deltoid area is the most commonly used injection site, and the most common adverse effect of the vaccine is injection site pain, inflammation, and the formation of a characteristic scar. Some people don't have those scars. I personally don't, but most vaccinated people have one. If administered subcutaneously by accident, the vaccine can cause a whole variety of side effects. BCG strain can spread into regional lymph nodes and cause their inflammation. More rare and severe cases present with abscesses, formations filled with pus that will need to be drained, osteomyelitis, which is bone infection, and in extreme cases, life-threatening dissemination. More severe cases appear in severely immunocompromised children that still have been given the vaccine. Let's note one last thing. Many countries have excluded BCG from their vaccination schedules aside from high-risk children. There are two primary reasons for it. TB is a rare occasion in those countries, and the overall epidemiological situation is good. The standard tests for exposure to MTB are performed in all children. Once they get vaccinated with BCG, those tests are used to monitor the efficacy of their immune response, and they can't be used to diagnose patients with clinical forms of TB. Well, they can, but their significance and accuracy are drastically reduced. So, those countries also want to diagnose TB exposure in a simpler manner. Risks and benefits. BCG probably presents the highest risks among vaccines. Children are almost guaranteed to experience a local reaction that's supplied with transient pain, and a small scar forms in most people. More severe cases have seen a drop in their rates of occurrence with the introduction of special BCG injectors and routine monitoring for congenital immunodeficiencies. The benefits of vaccination have been rather questionable. I'm going to repeat myself, it doesn't truly protect you from TB, but if you do get infected, severe forms are less likely to develop. Also, many countries have achieved much better control of TB since starting mandatory vaccination. And it also makes sense that some countries withdraw routine use of BCG. There is simply no need for it with their present situation. Mandatory vaccination is suitable for high-risk groups and developing countries that struggle with TB infection. For others, they can honestly try without it. So as far as the risks, children are almost guaranteed local reactions and a small scar on their shoulder. More severe reactions are generally the result of incorrect injections and undiagnosed immunocompromise, but can also happen in routine cases, rarely. On the other hand, there is no guarantee that the vaccine will protect you from the disease, but it can lower the incidence and the severity of cases. To be fair, I still believe it's a good idea to routinely vaccinate against TB, but countries are also free to make their own decisions regarding BCG vaccination. It costs a lot of money and provides questionable benefits. In terms of finances, it could be less beneficial for them to routinely vaccinate everyone rather than provide treatment for select few cases. If your country doesn't administer BCG, it's probably because the epidemiological situation with TB is pretty good, and it also allows them to pass BCG vaccination. That's everything I wanted to cover when it comes to TB, and I'll see you next with rotavirus.